Hello, my name is Tara Alta-Peter, and I'm pleased to join you today. I work at FDA in the Division of Gastroenterology, and I've had the opportunity to be involved in many drug and biologic development programs in this space over the past 5 years. Today, I will provide a brief overview of some of the opportunities where biomarker development could aid in drug development in the IBD space. These are my standard disclaimers. So let me first start by defining a biomarker. A biomarker is a defined characteristic that is measured as an indicator of normal biological processes, pathogenic processes, or biological responses to an exposure or intervention. Biomarkers can be molecular, histologic, radiographic, or physiologic characteristics, but are by definition not a direct measure of how patients feel, function, or survive. Biomarker data are being collected and analyzed in many, if not all, ongoing commercial drug development programs. Use of established and novel biomarkers is common, but not necessarily standardized. Some of these biomarkers have been around for some time, such as C-reactive protein or fecal calprotectin, and have known limitations that affect the degree of confidence that we have in the results. These limitations could include known low sensitivity or specificity to accurately measure disease activity in IBD, but also uncertainties around standardization of assay methodologies or sample collection techniques, derivation of normal reference ranges, or other issues. In other cases, a biomarker may be highly specific to a particular drug or biologics mechanism of action, and so extensive and longer-term data to validate its performance characteristics may not yet be available. So there are many different categories and potential uses for biomarkers. I have a link here on the slide to the BEST resource, which many of you are likely familiar with. If you are not, it is an online, frequently updated resource, which includes a glossary of terminology and specific definitions relevant to the use of biomarkers in research. A given biomarker can at times be used in more than one way, depending on the intended context of use. I will note a few examples in the following categories where opportunities exist to develop and use biomarkers to aid in advancing IBD drug development. So first off, we have pharmacodynamic response biomarkers that can be used to measure if a biological process has occurred in an individual exposed to a given product. Such a biomarker could have multiple applications as noted here. The first, and perhaps underappreciated, potential use of this type of biomarker could be to aid in dose selection. Over the last several years, as the space becomes more competitive, a trend is emerging where traditional dose exploration in well-conducted, dedicated phase 2 dose-ranging studies is sometimes rushed or skipped over altogether. The importance of finding the right dose and characterizing exposure-response relationships remains paramount, and so the use of biomarkers to improve the dose selection process could be useful. The second example, assessing utility of continuing longer-term treatment, could be helpful in IBD, where decisions about treatment are sometimes made at an early time point, where signs and symptoms of the disease may not yet have come under full control. A biomarker capable of detecting that a change or improvement in some aspect of the underlying pathophysiology of the disease is occurring could be useful to signal which patients are likely to ultimately show substantial clinical improvement or achieve remission if given adequate time. Another potential use of a pharmacodynamic response biomarker, albeit in limited situations, may be as a validated surrogate endpoint. A validated surrogate endpoint is one that is well established to be associated with clinical benefit. For example, blood pressure is a pharmacodynamic response biomarker that is utilized as a primary endpoint in clinical trials because it has been shown to be a validated surrogate for stroke, MI, overall mortality, and heart failure based upon data obtained from more than 500,000 patients across multiple randomized trials. As many of you are aware, FDA does have the formal biomarker qualification program, and at times we receive proposals aiming to develop a biomarker to replace the need for colonoscopy in IBD trials. Such a biomarker could be useful to reduce the burden of trial participation on patients by reducing the necessity for multiple colonoscopies, and could make trial participation more attractive to potential patients. However, it is important to acknowledge that to establish a biomarker as a validated surrogate endpoint typically requires multiple, large, well-conducted prospective trials that can clearly identify how the measured change in the biomarker correlates with a clinically meaningful outcome. My point here is not to discourage such intentions, but rather to be clear that developing pharmacodynamic response biomarkers does not have to be an all-or-nothing approach. Early data may be sufficient for an individual firm to feel confident using a biomarker as an aid in selecting a dose or to help to inform whether or not patients should continue on drug at an early time point. A stepwise approach over time to hone and further develop such a biomarker can be taken, even if the end goal may remain to develop and validate a novel surrogate endpoint that could be used to support approvals in the future. The next category is predictive, which is used to identify patients more likely to experience a particular effect from a given treatment. It may help to identify those most likely to benefit from a particular drug's mechanism of action, or on the other hand, to help exclude a subpopulation that have a biologic reason to be unlikely to respond to the treatment. To give a simplistic example, if you are developing a product with anti-inflammatory action, you may want to ensure the enrolled population has a high inflammatory burden at the time of randomization in order to best demonstrate the product's beneficial effects. Selecting the appropriate population most likely to benefit may help make trials more efficient and potentially down the road, if the biomarker was commercially available, could help clinicians who are in the position of having to choose a therapy out of an increasing number of options to really take an individualized personal medicine approach. The third category is monitoring biomarkers, which are measured serially and are used to assess disease status over time. As those familiar with IBD treatments are aware, the goal of treatment is to induce remission and then keep patients in a state of remission long term. Currently, we encourage the use of various non-invasive measures, for example, the Crohn's Disease Activity Index or partial Mayo scores, focusing on patient-reported signs and symptoms, to help assess patient status in between formal assessments that include colonoscopy. However, we know there are limitations to this approach because signs and symptoms do not always correlate well with the presence or absence of active inflammation on colonoscopy. Monitoring biomarkers could be helpful in this setting. Along the same lines, in clinical practice, it is not common to conduct regular colonoscopies in patients who are feeling well. However, at times there may be a lag between when the disease becomes active and when patients start feeling increasing symptoms. Thus, monitoring biomarkers that could identify early active disease flaring up could be useful. Last, but certainly not least, we are always interested in better ways to monitor and promote patient safety. Safety biomarkers come in different flavors and can be used before or after exposure to a drug to indicate the potential for, presence of, or extent of toxicity. One example of a safety biomarker well known to the community is TPMT testing prior to initiation of thiopurines, which is widely utilized in clinical practice as a means of predicting which patients are at greatest risk from drug-related toxicity specific to that agent. Other examples that are not IBD specific but are commonly used include serum creatinine to identify patients experiencing nephrotoxicity, or transaminases and bilirubin used to identify potential hepatotoxicity. As the arsenal of IBD treatments continues to expand and new agents with differing toxicity profiles emerge, additional biomarkers that can be used to predict or avoid toxicity will be of value. So in summary, there are a number of ways in which biomarker development can promote safe and efficient IBD drug development. Developers of biomarkers should always keep the intended context of use first and foremost in their minds when designing a program to validate the biomarker. Both formal and informal pathways toward biomarker development are available, and our division remains eager to collaborate with interested parties in this space. Thank you for taking the time to listen today.